which will be presented by our young ophthalmologists. And I would just request them to kindly follow the time guidelines and restrict to the 5 minutes presentation each time. I hope all of you are here. I can see 4 or 5 of you. So if someone is missing, then they'll be marked as absent. So we can start off, and I'll call the first presenter, Dr. Prudhi Venkateshwarlu, to present her work on Purtscher-like retinopathy in SLE, an uncommon cause of sudden vision loss. Yeah, I'm sorry. The chief author is Dr. Sai Deepthi Reddy. That's it. Sorry.
Good morning, faculty, and good morning, everyone. I'm going to present on Purtscher-like retinopathy in systemic lupus erythematosus, an uncommon cause of sudden vision loss. Common ocular manifestations of SLE are dry eye syndrome, retinal vasculitis, and choroiditis. Purtscher's retinopathy is a rare ocular condition, often associated with trauma, pancreatitis, head injury, characterized by sudden vision loss. And Purtscher's-like retinopathy is similar but distinct condition with retinal findings resembling Purtscher's retinopathy. It can occur in the absence of trauma and often associated with systemic diseases like SLE, scleroderma, and other connective tissue disorders. Case: a 23-year-old female with a history of mucocutaneous and neuropsychiatric manifestations of SLE was referred from the medicine OPD to the opthal for the decrease in the sudden vision loss. On general examination, she has a very high disease activity of SLE disease activity score of 40, which is high, presented with sudden onset of vision loss, which is painless in left eye followed by the right eye. On ocular examination, on the right eye, visual acuity was 636, improving to 624. On left eye, it was 636 and not improving. In the right eye, strongly suggestive of the Purtscher's-like retinopathy, secondary to systemic lupus erythematosus. Treatment was given for the left eye. We have done pan-retinal photocoagulation to the left eye, and also we have given high-dose corticosteroid therapy. The patient responded well, and we have seen resolution of the retinal hemorrhages and cotton wool spots in the left eye. Purtscher's-like retinopathy in SLE is a rare ocular manifestation. Retinopathy in SLE ranges from 3% to 29%. On fundoscopic findings, the pathognomic features would be like cotton wool spots due to microangiopathy, retinal hemorrhages, and Purtscher's flecken. All these are seen in the nerve fiber layer. Pathognomic feature, as already discussed, was polygonal areas of the retinal whitening with clear demarcating lines between the retina and the normal retinal vessels. And Purtscher's-like retinopathy is rare in SLE actually, and early recognition and aggressive treatment with high-dose steroids and pan-retinal photocoagulation can lead to favorable outcomes. This case underscores importance of considering Purtscher's-like retinopathy in the differential diagnosis of vision loss in SLE patients. Thank you.
One question. The patient of SLE, you got Purtscher retinopathy. So, patient was on immunomodulator or not? What?
Yes, sir.
He was on treatment.
Because
with the treatment, these findings you got, no? The patient was under treatment for SLE or?
Yes, sir. Because the disease score was very high, She has both neuro psychiatric and mucocutaneous.
In spite of treatment, this complication occur.
Yes, sir.
Thank you, Dr. Sai. Now I would like to call upon Dr. Karthik VR to present his paper on case series of retinal artery macroaneurysms and different treatment modalities.
Good morning. I would like to present this case series on retinal artery macroaneurysm and the various treatment modalities which was undergone. So coming to the introduction of retinal artery macroaneurysm, it was coined by Robertson in 1973. So basically retinal artery macroaneurysm defines as the focal dilatation of the retinal arterioles ranging from 100 to 250 micrometers, usually affecting the first three orders of bifurcations and at the AV crossing points, affecting mainly the supratemporal arcades and infratemporal arcades. And based on their presentations, the RAM can be hemorrhagic, quiescent or exudative. And 2/3 of patients usually will have a history of hypertension. There are various theories for pathogenesis of retinal artery macroaneurysms. It can be due to the weakness in the muscularis layer which develops leading to aneurysmal dilatations. So coming to this case series, we have seen 4 cases who presented to the OPD. We evaluated them with vision and regular ophthalmologic examinations, out of which the 3 patients who had macroaneurysms and the exudations near the macula and the supratemporal quadrants were underwent panretinal photocoagulation were followed up, and 1 patient who had a lesion which was away from the macula nasal to the wrist with normal vision, and we were advised for conservative management and followed up. So this is the case profile of the 4 cases. Most of the patients were above the age of 65 years with a history of hypertension, and the fundus examination was performed to reveal the features of aneurysmal dilated arterioles and the exudation, and the fundus fluorescein angiography was also performed for the 3 cases. So coming to the case 1, we did on the fundus photograph, we can see then the supratemporal involvement with the hemorrhage and the exudation, with fundus fluorescein angiography revealing the same aneurysmal dilatation as hyperfluorescent areas with focal areas of leak near the macula. And this is case 2. Actually, the patient had presented with vitreous hemorrhage, and upon resolving of the hemorrhage, we could get this fundus image, and again there is a supratemporal arteriole involvement mainly at the crossing point, and again in the fluorescein angiography we were able to see the dilated vessel. And this is case 3. This patient actually didn't have much visual complaints, and we could make out this supratemporal quadrant involvement. And the case 4 also, it was an incidental finding. The patient on screening had this aneurysmal dilatation nasal to the disc with some amount of exudation, and the OCT was performed to reveal the dilation. And the cases 1 to 3 we had advised for panretinal photocoagulation, and on follow-up there was a resolution of the hemorrhage and exudation as seen in the image. In the case 2 also, like post resolution of the VH, we had done laser photocoagulation in case 3 also. So among the 3 patients there was an improvement in the hemorrhages and exudation post laser, and in the last case we followed them up, and there was no deterioration or any hemorrhage which increased, so the patient was also stable with their vision. So there is no standard treatment guidelines as of now for retinal artery macroaneurysm. It's mainly based on the position level of the macroaneurysm. Previous studies mostly suggest it's a self-resolving course. Non-surgical management is generally preferred, and laser photocoagulation itself has some complications related to it, so its use is actually restricted. And anti-VEGF agents has proven in cases of huge amounts of exudation and edema to resolve the symptoms related to vision, and OCTA has been a newer diagnostic modality which has been used. So in conclusion, based on the level of the retinal artery macular, the distance from the fovea, other factors which affect with the prognosis, and the different treatment imaging modalities will help, and we have to tailor based on each patient whatever treatment is required. And these are my references. Thank you.
Well presented, Dr. Karthik. Any questions from the
You
panel?
mentioned that you did pan-retinal photocoagulation. Was it pan-retinal photocoagulation or something else? Focal to aneurysm was done. That was mentioned. You said multiple modalities of treatment, but you mentioned only focal to aneurysm. Did you give anti-VEGF?
No, we didn't give any anti-VEGF for these patients. We give after the sitting of laser only. The patient had improvement in their vision, and on follow-up also the vision remained stable. So
Your title says different treatment modalities. You have given only focal to aneurysm.
and conservative management, like
What conservative management you given?
no, we just like to follow up if there is any rupture of hemorrhage and all, the patient can present with later stages with diminution of vision. So
What you mean by conservative treatment? What kind of treatment?
like
In one patient you have given, you mentioned in your presentation. In your presentation, you mentioned that in 2 patients you have given laser, and 1 patient was managed with conservative treatment. So what conservative treatment you have given?
we are not
So it's usually in few cases of RAM, you really don't need to do much because they can self-regress also. All you need is a good
they
control
can
of their
undergo
hypertension.
thrombosis
Yes,
and
yeah.
self
And
So it's
most
the
important
management
is
of
hypertension control.
hypertension
Control. That is most important.
Thank you. So after this, I would like to call upon Dr. Priya Sharma, who will be presenting on correlation of corneal hysteresis and ocular blood flow in retinal vein occlusion. Seems quite interesting. Is she here today? She's not around?
No?
We can mark her absent, sir, or carry on?
Then
with-
go ahead.
The next presenter is not here today, sir. So should we mark her absent or wait for her and carry on with the next one? Next one, okay. So since she is not around, so I would like to call upon Dr. Ram Chandar. I hope he's there. No, okay. So the next is Dr. Doridal Reddy Mavuri. Is he around? He's also not there. Okay. So the next speaker, Dr. Shivani Yadav. No, all of them are absent. Okay. The last one up on my list is Dr. Pratyush. Okay. Thank you for being here today. So you will be talking about macular vascular density changes after cataract surgery in diabetics, and you have compared it to the non-diabetics using non-invasive OCT angiography. Okay. Welcome.
Very good morning, respected judges, panelists, and media colleagues. So, my study is on macular vascular density changes following cataract surgery in diabetic patients compared to that of non-diabetics using OCT angiography. I have nil financial interest. So, diabetes, as we all know, is one of the most widespread disease. Cataract and diabetic retinopathy often coexist. Cataract surgery can improve vision, but at the same time, it can accelerate the progression of diabetic retinopathy with macular edema. OCTA, a brand new non-invasive vascular imaging method which detects microvascular modification early in diabetic retinopathy. So through Octa, we have compared and drawn the data of macular thickness, the superficial and the deep capillary plexus, and foveal avascular zone before and after the cataract surgery. The aims and objectives were, so we divided the whole group into two groups. Group A consisted of diabetic patients ranging from no diabetic retinopathy to moderate NPDR, and group B consisted of non-diabetic patients, and both of them were compared pre and post operatively. Then we analyzed the consequence of phacoemulsification surgery on progression of diabetic retinopathy. So cataract patients were assessed for the eligibility. Patients who followed the inclusion criteria were taken, and we excluded the patient who were not fitting into the inclusion criteria. We conducted the ophthalmological examination and again divided the patient into two groups, group A and group B. Baseline parameters were taken, which included the vision, slit lamp examination, intraocular pressure, fundus examination, macular OCT, and Octa. An uncomplicated phacoemulsification surgery was performed, and then these data were evaluated on day 1, 7, day 30, and day 90. And then we did a comparative analysis. So this is one of the example of the Octa image that we got, and then we compared it using a software called Octava. These again are the images on post of day 1, 7, day 30, day 90. These were the results. We will be comparing the result in the following slides. So macular thickness, as we can see, we see an increasing trend for the diabetic patients till day 7. Then there is a plateau that is following from day 7 to day 30. And from day 30 again we can see a rise in the trend. Similarly for non-diabetics, we can see an increase till the day 30, and then the value decreases post day 30. Similar pattern for the SCP, we can see a steep gradual rise for the diabetic patients throughout from day 1 to day 90. Whereas in the non-diabetics, we can see a decreasing trend post of day 7. These data, when compared, both of these were found to be statistically significant. For the DCP as well, we can see an increasing trend post 30 days and a decreasing trend for the non-diabetic groups post 30 days. The FAS again was compared and we found similar result. Correlation analysis, the other group were non-significant, the HbA1c blood pressure, but important thing to note, the visual acuity again was non-significantly different. So coming on to the discussions, it's a long known fact that phacoemulsification causes an increase in the diabetic retinopathy progression, macular edema. There is development and progression of diabetic retinopathy after cataract surgery. Studies done by Otsi et al., Chiungai et al., Thomas Hong et al. All proved the same. Leifeng et al., as we know, study highlighted the macular thickness rise after cataract surgery in both the groups, while there was only the increase in SCP. Zhao and et al. Showed us that the phacoemulsification diabetics causes transient increase only in the DCP values. In our study, we observed progressive increase in the macular thickness from day 1 to day 90 and significant in both the groups. Pong et al., he summarized the mechanism and told that there can be some inflammatory mediators that are responsible for this. The SCP and the DCP values became significantly higher at 3 months post-operatively. Yu et al. Stated a considerable increase in the perfusion and the vascular density in both SCP and DCP after the surgery. So to conclude, we can say that SCP-DCP density increases significantly only in diabetic patients at the end of 3 months after cataract surgery, which may have a predictive effect on the progression of post-operative DR. So we can have a concluding statement. We should avoid rushing cataract surgery in early to mild-grade diabetic retinopathy patients. And Octa has indeed proved to be a valuable tool in detection of early DR changes. These were some of the limitations of my study. It was definitely a small sample size. We had limited time frame to conduct the study, and it was a single-centered study. These were my references. Thank you.
Thank you. Well, any questions?
Good presentation.
Thank you, ma'am.
So, did you in your inclusion criteria, you had patients with ranging from no diabetic retinopathy to great, except for severe diabetic retinopathy was not included in
Not
your study,
included, yeah.
right?
Okay.
So, was there any difference in the vascularity in patients who did not have diabetic retinopathy and who had mild to moderate diabetic retinopathy?
So that is the thing, ma'am. In the non-diabetic groups, also we found an increase even after phaco surgery. But there, after say 30 days to 7 days, the pattern was decreasing. It was coming to normalcy.
You said
But
the
in
density of
SCP,
vascularity.
SCP and
reduced.
DCP were again decreasing, but for the diabetic group, it was increasing.
So what is the reason for reduction in density of the vascularity?
So, ma'am, the inflammatory factors were transient in case of in both, but the amount and the degree of say the leakage that was happening, the inflammatory factors that were coming into play in diabetic patients were much large, so it couldn't come back to normalcy. Whereas in non-diabetics, there were no other factors playing into play.
What was their glycosylated hemoglobin values and their sugar control?
HbA1c was under control, ma'am. We didn't
All
cross
the
the value
patients?
6 point. Yes, ma'am. We have
In spite
included.
of control of diabetes?
Yes, ma'am. Yes, ma'am. We only good, well-controlled diabetic patients were taken, ma'am. And also, ma'am, the vision didn't. We didn't intervene in any of the study because the vision was not decreasing. It was not significant decrease. So we didn't intervene. Only it was at the vascular level that was we found the change.
It's a reduction of the pericyte cells in case of the diabetic.
Yes, sir.
This may be a factor for the thickness of
Yes,
the
sir.
fluid.
Microaneurysm. We have leaky vessels. That is the study that was done by you. He proved it was leaky, and thus there was increase in the macular thickness.
One
Okay,
question.
thank you.
There
Thank
was
you.
increase in macular thickness in both the group, no?
Yes, sir.
Diabetic as well
And
as
non-diabetic.
no. Is there any other factor rather than cataract surgery which plays role in increasing the macular thickness? Like
in general,
steroid for 2 months, can it increase the macular thickness? Did
yes,
you
sir. Yes, sir.
notice this point or not?
Yes, sir. It can have, but mostly it was
Is
not.
there any study where steroid can cause increase in macular thickness?
Macular thickness? Not that I'm aware of, sir. But mostly steroid-induced retinopathies are leading to CSRs. So intracystic or macular edema.
We have to rule out that factor also,
Yes,
whether
sir.
cataract surgery itself causing macular thickness or maybe due to long-term steroid.
Yes, sir.
Because both the group we are getting increase in the thickness.
Yes, sir.
So that factor also should be considered.
Yes, sir.
Thank you.
Thank you, sir.
So I think that was the conclusion of the first part of today's talks. Now we have to move on to the finals, and there was supposed to be 2 presenters for that. Do we have Dr. Gaurav Mahajan? No? Okay. I think so. So that's it. No more presenters. So they'll be all marked absent, and the results will be tallied amongst the ones who have been able to present today. Thank you, everyone. Thank you.
We can call them for group photograph, all the participants.
I would request all the participants to please come forward up to the dais for a group photograph.
In the right eye, strongly suggestive of the Purtscher like retinopathy, secondary to systemic lupus erythematosus. Treatment was given for the left eye, where we have done pan-retinal photocoagulation to the left eye, and also we have given high-dose corticosteroid therapy. The patient responded well, and we have seen resolution of the retinal hemorrhages and cotton wool spots in the left eye. Kushner's-like retinopathy in SLE is a rare ocular manifestation. Retinopathy in SLE ranges from 3% to 29%. On fundoscopic findings, the pathognomic features would be like cotton wool spots due to microangiopathy, retinal hemorrhages, and Kushner's flecken. All these are seen in the nerve fiber layer. Pathognomic feature, as already discussed, was polygonal areas of the retinal whitening with clear demarcating lines between the retina and the normal retinal vessels. And Kushner's-like retinopathy is rare in SLE actually, and early recognition and aggressive treatment with high-dose steroids and pan-retinal photocoagulation can lead to favorable outcomes. This case underscores importance of considering Kushner's-like retinopathy in the differential diagnosis of vision loss in SLE patients. Thank you. Thank you.
One question. The patient of SLE, you got Purtscher retinopathy. So, patient was on immunomodulator or not? What?
Yes, sir. She
He was on treatment.
Because
With the treatment, these findings you got, no? The patient was under treatment for SLE or?
Yes, sir. Because the disease score was very high. She has both neuro, psychiatric and mucocutaneous.
In spite of treatment, this complication occurred.
Yes, sir.